All right, we'll go ahead and get started. Welcome, everyone. Thanks for joining us today. I'm Shannon Udy. I am the program manager for the Good Health and Wellness program at the Great Plains Tribal Leaders Health Board. And our webinar today, Chronic Disease Prevention Across the Life Course, is a part of our monthly community health webinar series. And our presenter today is Dr. Christine Hockett. And before I dive in and really introduce her and let her start her presentation, I just want to go over very briefly a few housekeeping items. Everyone, currently all attendees are muted. So if you do have questions or comments or want to introduce yourselves, please feel free to use the chat box. Just make sure to change the settings to everyone instead of hosts and panelists if you would like to communicate with everyone and not just us. Feel free to put your questions in there. We will address questions towards the end of the webinar. There's also the Q&A feature at the bottom of your screens that you can use to input questions throughout the webinar as well. So we'll be checking both the chat and the Q&A towards the end to answer any questions that anyone has. This webinar is being recorded, so we will be sending up a follow-up email to anyone that doesn't have a chance to join us today. It will be uploaded to our YouTube channel, so you have a chance to go back and view it again at a later time. So without further ado, like I said, our presenter today is Dr. Christine Hockett. Dr. Hockett is the Director of Community Research at the Avera Research Institute and an assistant professor in the Department of Pediatrics at the University of South Dakota School of Medicine. Her research examines how modifiable factors on an individual and social level may shift the trajectory of chronic disease risk throughout the life course. She uses both observational and interventional methods to identify and target health behaviors that can reduce the risk for diabetes and obesity and improve the health of future generations. During her presentation today, she'll be discussing the life course epidemiology of chronic disease in Indian country and culturally tailored interventions developed to reduce the risk of chronic disease in American Indians across the life course from childhood to adulthood. So thank you so much for being with us today, Dr. Hockett, and I will pass it over to you to get started.
Great. Can you hear me?
Yes.
Okay, great. All right. Thank you, Shannon, for the introduction, and thank you for inviting me to present today. So to start, I'll just tell you a little bit more about myself. So I was originally born in Cincinnati, Ohio, and I moved to South Dakota when I was about 12 years old. And I recently, my family and I recently moved back to South Dakota to be closer to family and give back to the communities that we grew up in. And so while I was away, a lot of my professional work really focused around life course epidemiology and directly related to obesity and diabetes and cardiovascular disease. I worked on the Search for Diabetes in Youth study, which is a joint funded CDC and NIDDK diabetes registry that has multiple sites across the nation. My particular focus was working with the Colorado and Navajo Nation cohorts in diabetes case ascertainment. I've also had the opportunity to work alongside the Dene people with my colleagues at Colorado and UNC and helped develop a diabetes prevention program for Native youth, which I'll talk more about later in this presentation. So today I will, over the next 40 minutes or so, I'll present on the landscape of chronic disease in American Indians across the life course, and highlight some of the interventions that I work with and have been a part of, both here in Rapid City, but also in Navajo Nation. So just like I mentioned, just kind of an outline of the talk, looking at chronic disease in American Indians across the life course. We will then look at the prevention of chronic disease, and some interventions that are currently going on, native opportunities to stop hypertension, or what we call NOSH, and then also a pediatric intervention around reducing risk factors for diabetes, and that is tribal turning point, or what we call TTP. And then we're going to finish off with some external examples of successful community and policy level interventions to leave on a high note. All right, so what exactly is chronic disease? So we hear about it all the time, but as an epidemiologist, I always ask myself, like, what's the definition? How are we defining this? And, what's the comparison group? Who are we comparing these, what groups are we comparing together? And CDC defines chronic disease broadly as conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living, or both. And as many of us know, chronic disease impacts a significant proportion of Americans, and it is well established that it disproportionately impacts American Indian communities. Additionally, not only does it put us at risk for other diseases and conditions, but it also decreases our quality of life and can be very costly. So if you look at this table, this shows the top leading causes of death in non-Hispanic white American Indian and Alaska Natives. And as you can see, 4 out of the top 5 causes of death for both males and females of all ages were in some order of heart disease, cancer, unintentional injuries, diabetes, and chronic liver disease. And 4 out of 5 of those are chronic diseases. And so this just really shows the impact that chronic disease has on the mortality in American Indians. And so what does the morbidity or the prevalence of the top chronic diseases look like in the American Indian population? So about 30% of American Indian and Alaska Native adults have hypertension. And American Indian and Alaska Natives have the highest prevalence of diabetes in adults, and this is around 15% compared to any other US population groups. And this is more than double than that of non-Hispanic whites. And American Indians are also disproportionately affected by cardiovascular disease, which has been shown in the regional study here with the Strong Heart study. And so additionally, thinking about comorbidities, evidence has shown that diabetes, hypertension, low levels of HDL cholesterol, albuminuria, which is like a sign of poor kidney function, and elevated fibrogen were associated with cardiovascular disease in both men and women. And with diabetes having the strongest association with disease in both men and women. So one study found that men who had diabetes had a 2.2-fold increase in cardiovascular disease, while women had a 3.5-fold increase in the risk of developing chronic CVD compared to individuals who did not have diabetes. So in addition to being impacted disproportionately by the prevalence of diabetes, American Indians and Alaska Natives experience earlier onset and higher rates of comorbidities than other populations. And an example of this is diabetes. And so diabetes is a major contributor to the disproportionately high rates of CVD among American Indians and Alaska Natives compared to any other racial and ethnic group. And so recently, O'Connell and others published a study here in 2020 or 2021 using IHS data that showed that Native adults with diabetes had a higher prevalence of hypertension, cardiovascular disease, and kidney disease across all adult age groups and increasing with age. So now that we've typically thought, now in the past, we've typically thought of chronic disease to impact adults only. These were diseases that only affected adults. But for, and to kind of, as an example, type 2 diabetes, this was considered clinically as an adult disease. However, over the last 20 years or 2 decades, not only have we seen the incidence and prevalence of chronic diseases in children increase, but we've also seen them occurring at younger ages. And this is really disturbing. And so both diabetes and obesity are major health problems in Native youth populations, with up to 30% of American Indian youth being obese versus only 17% of all youth in the US. And so also we've seen that American Indian adolescents have up to double the prevalence of type 2 diabetes compared to other racial ethnic groups in the United States. So search for diabetes in youth, again, which has national representation and is the leading registry for youth with diabetes, found that there is a high prevalence of diabetes-associated complications and comorbidities in youth. And this is specific, they specifically looked at risk factors for CVD, such as high blood pressure, high LDL, and low LDL levels. And then I just wanted to kind of add to this that, the disparities that we've seen and that we see here in the previous slides have not only been seen in American Indian populations in the US, but other indigenous populations worldwide, such as the First Nations in Canada and indigenous populations in Australia. And the rates of type 2 diabetes are almost uniformly higher in indigenous versus non-indigenous groups, with some variation across the populations. So now that we've kind of talked about the importance, the impact about chronic disease, I want to talk about a couple interventions that focus on reducing the progression of chronic disease or the risk factors for chronic disease. The first intervention is called NOSH, and this stands for Native Opportunities to Stop Hypertension. And this is a study that was developed in collaboration with Washington State University, Partners for Native Health, and Oklahoma State University. And Avera Research Institute in Rapid City is a site for recruitment for this study. And so we've already seen that hypertension is a serious chronic disease and a risk factor for other chronic diseases. And so focusing on this, we know that heart-healthy diets can improve blood pressure control with and without medication. The DASH diet, which stands for Dietary Approaches to Stop Hypertension, is a lifestyle diet intervention for primary and secondary prevention of cardiovascular disease. And so this has already been shown that the DASH diet lowers systolic blood pressure by about 11 units in a participant with hypertension. And so this study really focuses on evaluating a culturally adapted DASH diet to improve blood pressure in poorly controlled Native adults. And so really the specific aims around the study, again, is to evaluate the effect of this intervention, this culturally adapted intervention, on blood pressure and secondary outcomes. So our secondary outcomes are focused on BMI, heart disease risk, and fruit and vegetable consumption over a 12-week period in Native adults with high blood pressure. We also have a secondary aim, and this is conducted in a smaller study or a subset of the NOSH population. And this is to test whether providing 6 additional weeks of dietitian support, this is without the grocery stipend, which you'll learn about in just a second, can help improve blood pressure over the long term. So this is currently a randomized controlled trial. And this uses the DASH diet, which again is the dietary approaches to stop hypertension. And this is a lifestyle program that helps control blood pressure by encouraging a low salt, low fat diet with lots of fruits and vegetables. However, the DASH diet has never been tested in American Indians. And so really the goal around this study is to design an 8-week DASH intervention, again, to improve blood pressure control. And so what we did is we tailored the DASH curriculum to American Indian culture and values, and we'll talk about kind of how we did that in a few slides. It really emphasizes the low salt diet and the traditional native foods. So what happens is once enrolled into the study, if the individual is randomized to either the intervention group or the waitlist group, and the intervention group receives a 1-hour in-person consult, with COVID, it doesn't always happen in person anymore, but a 1-hour consultation with a dietitian. And that happens in the first week of the intervention. And then following that, they meet, they have weekly meetings with a health coach and have these individualized one-on-one sessions to kind of talk through in detail more about the NOSH diet, and kind of have the health coach kind of helps them and works with them to maybe problem solve any problems that they have around goal setting, educate them around the NOSH diet, and so on and so forth. So both groups get a weekly food credit of $35. And they are both required to report weekly blood pressure readings. The waitlist group gets just kind of a standard of care, kind of American Heart Association booklet, and also has meets with the health coach, but not to necessarily receive education, but to put in their weekly grocery order and to report their blood pressure. I will say that after the intervention or the 8-week period, those that are in the waitlist group do have the option to receive the intervention if they're interested. Everybody receives a blood pressure monitor, and then we have 3 research visits which happen at baseline, 8 weeks, and 12 weeks, where we collect questionnaires and a 24-hour urine sample, which they do get compensated for. So what did the participants look like? So these recruitment is occurring or has occurred in 4 sites across the US. And this study is really hoping to enroll about 370 American Indian adults. They do have to have high blood pressure, and this is defined by having a systolic blood pressure greater than 130. And this is at enrollment. Participants can be taking antihypertensive medications. However, their medication regime needs to have been stable for at least 6 months with no plans to change. And then also we do obtain provider approval for the participants to participate in this study. And then the providers do receive updates on kind of what was discussed and how the participant has participated in the study. So this just gives a quick overview of kind of what this study design looks like. So let's say we have a participant who's been referred to us by a physician or by their doctor, and they give us a call. We talk with them. If they're interested, if they're interested, we talk to them about study. We consent them. They complete a baseline visit. this happens, this is where the consenting happens. They receive the blood pressure machine, and they take the initial questionnaires and initial blood pressure readings. Then we have about a 1 week compliance period. So this is where they are asked to take 4 to 7 days of blood pressure measurements, and then come back to our clinic about a week later and report those blood pressure measurements and provide a 24-hour urine. At this time, they're randomized, and they either get randomized into that intervention group or the waitlist group. Then the intervention occurs over an 8-week period, and we ask them to come back for a second research visit at 8 weeks and then a follow-up visit at 12 weeks. So thinking, we had talked about how NOSH is a culturally adapted version of the DASH diet. And so I just wanted to kind of touch on some points about, really the 2 types of adaptations that that we have made to the DASH curriculum. So the first adaptation is focused on the cultural and local adaptations. And this incorporated topics and information around food preferences and eating habits, access to local and available native foods. So for example, salmon, bison, wild rice, wild food preferences and familiarity. So making sure people knew what some of these food items were if they were unfamiliar. Cooking demonstrations with local, native, and NOSH foods. We then had the other type of adaptation was focused on clinical adaptations. So dietitians tailored the NOSH eating plan based on medical conditions, because we know that we do see a lot of comorbidities occur in those who have chronic disease. So what does this look like? What does the NOSH diet look like for somebody who has hypertension and diabetes? And then they also tailored the eating plan to include blood pressure management knowledge, attitudes, and behaviors, and then facilitators and challenges to hypertension management. So as a result, the adapted NOSH diet now uses the DASH curriculum with the promotion of native foods such as game, fish, roots, vegetables, and wild berries. And it focuses on fruits and vegetables, low dairy products, whole grains, seeds, and nuts. Overall, it has fewer sweets and added sugars, and less red meat than the typical US diet. And similar to the DASH diet, it is low in sodium and high in potassium. So I just want to first acknowledge and thank the funders of this study, the study participants, the clinics and the staff, the PIs and project lead for this study. We are currently, this study is still ongoing, so unfortunately I can't share any results with you today, but hopefully I can come back at a later date and provide and share those with you. But we are still recruiting. And so, of course, I'd have to put a plug in. And so if you are a native adult with hypertension or know somebody that may benefit from this program, please feel free to reach out to us, and we can talk more with you about this program and how you may be able to participate. So now we finished talking about a program focused on adults. And now we want to focus on the next generation, so our children. And as we talked about in the beginning, both diabetes and obesity are major health problems in youth, and particularly Native youth. And there's compelling need for prevention that has been long recognized by tribes and researchers alike. And so, but unfortunately, there hasn't been much success to date in addressing some of these growing problems. So this is just one attempt into kind of taking what we know and implementing this and creating an intervention specific to Native youth to try to prevent risk factors for diabetes. So the study I'm going to talk about now is Tribal Turning Point. So Tribal Turning Point started back in, I think, 2015. And really the goal of this project was to create a culturally appropriate multi-component intervention to reduce type 2 diabetes risk in Native youth. And the development of TTP, the development of it all began in 2008 when UNC researchers partnered with Cherokee Choices, which was an ongoing CDC-funded program of community-based health interventions in Eastern Band Cherokee Indians in North Carolina. And Cherokee Choices was offering the Native version of the DPP program, which is called the Lifestyle Balance. And this was particularly focused, this was developed for adults, and it has been shown that it promotes weight loss and prevents type 2 diabetes by 58% in high-risk adults. And so what we wanted to do is the Cherokee group wanted to help adapt the Native lifestyle balance into a youth program. So together, they developed a 10-session group class that included active learning kind of sessions to promote experimental learning, and was supplemented by individualized motivational interviewing based counseling. And so in 2015, we as in folks at the University of Colorado and with the Navajo community reached out to Cherokee Choices and asked them if we could work together to develop something similar for Navajo families. And so this was conducted with the support of an NIDDK R34 pilot. And we conducted, and what we did is we took the first kind of, this pilot was a 2-year pilot project. And during the first year, we conducted focus groups with Navajo families and community experts to discuss the appropriateness of the Cherokee teaching tools and resources, and the local resources for healthy living and strategies to keep participants engaged in the programs. And so working groups of academic and community partners developed a common curriculum with tribal specific, so Navajo specific material. And so just to kind of put this in reference, like, so for example, the language, the tribal customs, the local foods, the activities differed across Cherokee Choices and Navajo. And so what we did that first year is really review the Cherokee Choices and adapt it to the Navajo culture and Navajo communities. So we designed, and so as we, this process took a year and worked with both academic and community members to really develop this curriculum. And so what we ended up with was a program that could be delivered by a trained member of the tribe, so a non-native individual that was already integrated into the tribe or the community. But we thought it was important to have that community lay person be able to implement a program like this. And so the core curriculum that was developed was delivered through a 10-week activity learning group, or 10 weekly active learning group classes that lasted about 2 hours each. All the classes included a 10 to 20 minutes of physical activity, an interactive learning session with games or cooking demonstrations, and then a cultural activity in the form of crafts or maybe an elder coming in and teaching the youth about the local language, and then a group meal at the end. And the goals of TTP were presented as 5210. And so this is really referring to the target, this is really referring to the targets of eating greater than 5 servings of fruits and vegetables, having 2 hours or less of screen time, and 1 hour, at least 1 or more hours of physical activity, and 0 sugar sweetened beverages. And so given our specific goals for increasing physical activity to promote insulin sensitivity, each of the classes was preceded with a optional 60-minute kind of kids workout where they could come and play games and get their heart rates up. The second component of the curriculum was individual caregiver child MI sessions, or motivational interviewing sessions. And the health coaches were trained to use this interactive MI counseling and the principles around MI to identify stages of change and work with the participants in progressing to the next stage, and really help the participants develop problem-solving skills related to their behavior goals. And then the third component of Tribal Turning Point was the community resource toolbox. And so this toolbox was available as needed. And so this was really tailored to each of the communities, and those health coaches really worked on keeping it up to date and relevant to their group of kids and the needs within their community. And so just examples of resources included phone reminder systems, home food and activity environment reviews, and facilitating connections with community resources and services. So after developing the program, we conducted an 8-month randomized pilot study to assess the feasibility of delivery and program acceptability. So while this wasn't a school-based intervention, it was delivered over the academic year to align with the schedules of most families. And the core intervention occurred over 4 months in the fall and consisted of 10 group classes and 3 individual MI sessions. And the booster period occurred in the spring with 2 additional group classes and 2 or more MI sessions. And then the toolbox, of course, was available throughout the 8 months. Because this was a randomized pilot study, we also developed a series of health and safety classes that were delivered to the control group. And so 3 classes were held in the fall, covering a variety of just general health topics, such as drug and alcohol prevention, bullying, fire safety, and bike safety. We recruited participants for the pilot study and feasibility study in the summer, and baseline measurements occurred at the end of the summer. And then we randomized the participants to the intervention or the control groups and delivered the program with additional measurements conducted in all participants at the end of the core intervention period and at the conclusion of the study. So again, this was a pilot study. This study was done in both communities that we were working with, one in Navajo Nation and one in the Eastern Band Cherokee Indian Reservation. And potential participants were identified through existing relationships within each of the communities. And so what we did is we targeted youth 7 to 10 years of age who were tribal members and who were fit the following inclusion criteria. They were overweight or obese and had one primary caregiver willing to actively participate. The inclusion criteria included diagnosis of type 2 diabetes, serious health concerns that could interfere with participation, or plans to move out of the area. And then we formally enrolled up to 2 youth per family, and additional siblings were allowed to participate in the study and come to the sessions, but we didn't include them in the data collection piece of things. Within each tribe, we randomized the families to at the family level to the intervention or control group. So what did we find? So we enrolled 62 participants from 52 families, and youth were approximately about 9 years old at enrollment, with equal numbers of males and females. Almost all youth, about 94%, lived in households with parents who had at least some college education. And 32% of households had an annual income of above 50,000. At baseline, over 80% of youth met the BMI criteria for obesity, and mean fasting insulin, HbA1c, and blood pressure were all in the normal ranges. And baseline measures were similar between the two groups. So we observed a statistically significant treatment effect for our primary obesity outcome. And BMI remained the same in the intervention participants, but significantly increased among control participants, resulting in a significant treatment effect. However, this was attenuated in adjusted analyses. And then we also found that BMI Z-score decreased in the intervention group, but did not change in the control group. And group differences were significant in both the unadjusted and adjusted models. Waist circumference remained the same in the intervention group, but significantly increased in the control group, and the treatment effect was statistically significant. And then there was no treatment effect on our other primary outcomes, fasting insulin or other cardiometabolic outcomes. We did not see any significant changes in behaviors, so a change in physical activity, screen time, or dietary intake. But we did look at attendance, because the other part of this feasibility study was acceptability. And so attendance during the pilot study was among the intervention was very high. And so we had an average about 84% overall. And not surprising, the attendance was a bit higher during the core intervention period compared to the spring booster sessions that we had, or session that we had. Attendance among the control group was a bit lower, of 54%. However, the retention for the measurements, so getting them back to actually do data collection, was really great. And so we had at least 97% of participants complete measurements at each time point. And I think that just goes to show how important those community relationships are, and having that health coach be a community member and having those relationships with the families. So now in the Navajo culture and most Native groups, storytelling is highly valued. And it's a way of reflecting on the past and showing lessons with others, usually younger generations, and remembering where they came from. So at the end of this pilot study, we worked with the Healthy Native Communities Partnership to help the youth that participated create a digital story of their experience in TTP. And the kids, again, 7 to 10, wrote the stories themselves and recorded the audio and provided pictures and selected the music. And so I actually just wanted to share one of the videos that two sisters made together about their experience with TTP. Let me see if I can do this. Oh, no.
Grandma has diabetes and she gets herself shot. She tries to eat healthy, like she eats fruits and veggies. She gets exercise by working outside. We pick up trash and feed our to dog. We see her take her insulin shots every morning. We are thinking, does it hurt? Can you feel it? But we are scared to ask her. Diabetes is a sickness that makes her blood sugar go too high. The insulin helps to make it not go so high. Sometimes the insulin is too strong for her and her blood sugar will go too low. Then she will get weak where she can't walk, then her eye vision gets blurry. When she has low blood sugar, she has to eat or drink something sweet right away, but she doesn't want to. We want our family, everyone around, to change how they eat because they might get diabetes. If our family eats healthier, they might lose weight too. They can have a better life when they grow up. We tell them, but they still eat fast food. And we told them again, and they started to eat fruit for a while and went back to fast food and being lazy again. We are not going to give up. Keep on trying. Walk out that door. So funny. Don't be afraid of the storm.
Oh, sorry, guys. Okay. So I think this just gives you a little bit of flavor of these kids and what their life is like, what this program meant to them. And a common theme across all of the videos that were created was how prevalent diabetes is in the community and in their immediate family. Almost all the kids talked about a close family member who had diabetes and how the kids themselves understand how important healthy living is. And so I like this video in particular because it illustrates how the children that we work with could become the agents of change in their own family. So I just, so here are just a couple, oh, we missed the book. So I had there should be some pictures here of our celebration, but after the pilot study was done, we wanted to come back to the Navajo community where this was conducted and really celebrate with the community members and the participants and their families and thank them for what they've done and contributed to. So we had cooking demonstrations, we played games and made crafts, and then just enjoyed being together and acknowledging what we did together. So the next steps, and we're coming out of time and I want to be able to answer questions. So the next steps from this pilot study was to really look at, how could we realized that the results were promising, but it needed a little bit more work. And so we had some areas that we wanted to improve in the program. And so we did that. We wanted to look at whether or not the obesity measures, what we saw in the pilot study, were small. And we wanted to know if they were clinically significant and were these changes long-term, could we establish a long-term change over time? We also conducted the pilot study in a rural reservation. And so we don't know how that kind of applies to an urban setting. And so we wanted to try to involve some urban sites. And then we just wanted to better understand best practices for implementation before disseminating the program on a larger scale. So what we did is we applied for a R01 and got funded about 5 years ago. And so we are currently conducting a randomized controlled trial. that has grown considerably in both size and scope from the pilot study. And so we've included 3 sites, 2 rural communities on Navajo Nation, and then an urban community in Phoenix. And then the Cherokee group decided to opt out of the randomized control trial because they had continued to provide the TTP program within the community. And so we were concerned about scientifically about contamination between the groups because these efforts were ongoing there. But the Phoenix site, by adding that, we would be able to add that urban contrast and ensure that the program could work in all settings as well as, or in an urban setting as well as on the reservation. So we plan to recruit 300 participants. We have a similar design to the pilot. We have 3 MI sessions. We extended the follow-up time to 24 months. And then we also are doing qualitative interviews to better understand in a subset of people to just hear from them directly about what they expect to get from the program, how it has impacted their lives, and how we can make it better. So we have started our 5th year of this project. We were making really great progress, and then COVID hit, which I think is a common theme. But we've hired and trained 10 local staff members. And before the pandemic, we had enrolled 175 children across 4 cohorts. We completed 12-month data collection in 2 of the cohorts. And then mid-COVID, our staff really had to rapidly transition to remote program delivery and begin data collection with a non-contact protocol and start virtual recruitment efforts, which has been really difficult. Just an example of a non-contact protocol. Our research assistants would drive out into these rural settings and households and have a little Tupperware container that has been all wiped down. They'd be garmed up and they'd drop it off at the front door. And then the family would, after our research assistant had kind of walked away and left, the family would pick up, come out and take the remote data collection kind of box. And then they would try to Zoom call or phone and talk them through how to conduct the remote data collection, like height and weight and so on and so forth. So we had to get creative and it definitely pushed us to figure out new ways to collect data. But we are hoping to finish up recruitment this fall, and we'll begin data analysis in the spring. So this is just a thank you to everybody involved in the funding for these projects. And then I know I'm running out of time, so I'm not going to go too far into this, but I do want to just highlight some community and policy level interventions that have really had positive impact, at least within the Navajo Nation. And so these are 2 articles that have just been recently published and highlight the implementation and results of the Navajo fruit and vegetable prescription program. And so this program began in 2014 to improve access to fruits and vegetables among Navajo families and community members. And it's run by the Community Outreach and Patient Empowerment Program. So this is called COPE. And the really powerful thing, I believe, about this program is that it links the existing health infrastructure and the commercial food infrastructure together, while supporting kind of the growth within both frameworks at the same time. And they also support kind of the growing community-based efforts to reclaim the food production system, so as well as educate about nutrition and food preparation. So what this kind of looks like is they have families will go to the community health clinics or the community health workers. They will get a fruit and vegetable prescription prescribed to them. They will have to go to monthly educational sessions to be able to obtain these prescriptions. And then what the prescriptions do is they provide like $25, some type of monetary value to then go use at the local stores in the community and purchase fresh fruits and vegetables with those incentives or that prescription. And through these articles, they did show a significant increase in fruit and vegetable consumption between baseline and exiting the program at 6 months. Looking at the children who are overweight and obese at baseline, they did see significant changes in the BMI score and fruit and vegetable consumption. So that is really exciting to see as a community level intervention. The last intervention is at a policy level, and in 2014, in the Healthy Today Nation Act, the Navajo Nation implemented a junk food tax, and this started in 2015, or was implemented in 2015, and since then, this junk food tax that is across Navajo Nation has generated over $7.5 million in gross revenue, and nearly all of that money has been redistributed back into the Navajo chapters to develop their own community wellness programs. So the money goes back into developing parks and walking systems and walking paths, and however that kind of chapter or programs that chapter identifies as important to support healthy lifestyle and behavior. And this is my third and final thank you. So that is it. I'm open for questions.
Awesome. Thank you, Dr. Hockett. Yes, so please feel free to ask questions at this time. Again, you can either use the chat or the Q&A feature at the bottom of your screen. If you also just have a burning question that you would like to verbally ask, you can always raise your hand using the raise hand feature at the bottom of your screen, and I can unmute you. But we do have a question in the Q&A that asks, when folks meet with the dietitians, do they also teach traditional ways to prepare and store foods, for example, how to dehydrate meats and vegetables?
That is a great question. With this program and those dietitians, that is not included, or those type of topics are not included within that initial session with the dietitian. But that's definitely, that would be helpful. I think if somebody is interested in that or specifically asks about that, then the dietitian and the health educator work to try to help find resources for that individual if that's of interest for them.
Great, thank you. Another question, how difficult was transportation to get participants to the events?
Which for the tribal turning point?
It doesn't specify.
Yeah.
Yes.
Okay. Yeah, so interesting enough, this actually, I think transportation is always a big issue. And it was a larger issue in certain communities versus other communities. Interesting. And so we had typically, if folks had trouble with transportation, a lot of times our research assistants would actually go and pick them up and bring them to the sessions if that was of interest to them and they wanted to do that. One of the communities was very rural in Navajo. As like any, the roads in these rural communities are not well maintained. And so if you get a lot of rain, you can, barely drive on them. And so we have had some difficulty around just weather and people being able to drive in general because the roads are undrivable. And so we have had to work with that and work around that.
Yes, great question. Let's see. You might have mentioned this, but what was the current recruitment number for the hypertension project?
So for Rapid City, we are currently working to enroll 100 participants. And we are I think we have enrolled about 27 individuals currently.
Great. Let's see. Where can we find examples of long-term implementations that have made a significant difference?
Oh, that is a broad question. Is there a particular area that you're interested in? I think I would be happy to talk with them offline about that, maybe, if that works. Okay.
Yeah. We'll include Dr. Hockett's email address in the follow-up emails. So if you would like to reach out to her with some more specific questions, you can do that. We do have another question in the chat, and then I do see someone with their hand up, so I will get to them next. But can we get a list of the traditional foods that were used for both programs? We have an urban population, and so must work with varied tribal members.
Yes, I would be happy to share that.
We can include that in the follow-up email as well. Let's see, I am going to, Winona, if you would like to unmute, you can go ahead and ask your question.
Can you hear me?
Yep.
Okay, so just one question that I did have is whenever I would take my children to like the WIC office and they would weigh them, they have different scales, like for different ethnic groups. So like they would go by, okay, my child is 12 years old and he's supposed to be weighing so much, so how do you determine how a child is obese?
Yes, so we, in the Tribal Turning Point project, we use the CDC growth charts to look at that. And those are separated or take into consideration age and sex. And so those are the two variables. So that's what we look at in Tribal Turning Point. And that's what I've seen a lot. So I'd be interested to maybe talk with you further about kind of your experiences.
Thank you. I appreciate that.
Great. I don't see any other questions. There is just another comment. Thanks for answering the dietitian question. I can recommend a person who would be a great resource for traditional food preservation and preparation if interested.
Yeah, that would be great.
Yeah, awesome. Yeah, there'll definitely be some opportunities to connect again in that follow-up email. If you'd like to reach out to Dr. Hockett for any other questions or connections, you can go ahead and do that. I think I'm not seeing any others. In the meantime, I'm going to go ahead and put an evaluation link in the chat before hopping off. If you have time to take a quick evaluation feedback form, we really appreciate everyone's feedback and suggestions for future webinars. Otherwise, I think that's it, and we can wrap up. So I just want to say thank you again so much, Dr. Hockett, for joining us today and sharing all of this research and studies. So thank you so much. We really appreciate it. Thank you everyone for hopping on and joining, and keep a lookout for that follow-up email that will be coming either tomorrow or early next week. So thank you everyone. Enjoy the rest of your day.
Thank you guys. Have a good day.
Thank you.